everybody, and welcome to Gender Queries, a podcast about trans and gender diverse healthcare in Atlantic Canada. My name is Jess, and I use they and she pronouns.
I'm AJ, and I use he, they pronouns.
And my name is Sam, and I use they, them pronouns.
Just a quick content warning for this episode. There will be some discussion of self-harm and suicidality in youth as we review the evidence, so please listen with care.
Alright, Jess, today you're going to tell us all about pediatrics. That's a big topic. Where should we begin?
We probably need to address the elephant in the room, which is the CAS review. A big 4-year investigation that came out done by the UK's NHS into the scientific basis of treating transgender youth and the experiences of those involved in transgender care. We're not going to dig too far into it because a lot of folks have already done that, so we're going to link the Science Versus episode, which does a really, really good job of explaining some of the methodological flaws in the CAS review. However, basically the CAS review ended up putting a lot of skepticism on gender-affirming care of transgender youth and ended up leading to the shutting down of the NHS's gender identity clinics for youth, and it kind of gave folks who already were not supporting transgender youth fuel to shut down those services.
They're basically saying, in some respects, that according to the CAS review, there's evidence suggesting that youth that go through transition, whether starting puberty blockers or starting hormones, are more likely to be depressed or something along those lines. But they fail to acknowledge the fact that a lot of that was down to the stigma and the bullying that came with it, rather than the actual transition itself. And so it's kind of unfortunate because I feel like you said, it gave fuel to create policy changes. Mm-hmm. I mean, mostly in the UK. But I think why it's important in Canada, in Atlantic Canada, and even in the States, is you have this fuel that has ignited a fire in the people that don't agree with gender-affirming healthcare, and it's been perpetuated in the media. I think that's really the unfortunate part of it, especially when you have doctors or persons within higher education who, you're taught how to critique articles, and you have this CAS review that's over like 300 pages, and the people that are making conclusions from this CAS review are really just reading the summary of the CAS review.
Yes. WPATH and USPATH commented on the CAS review, and it's just a 3-page document. They essentially say that they are deeply concerned about the facts regarding the CAS review's process and content, as well as its consequences for the provision of care for trans and gender diverse youth, for various reasons. So it does go into critiquing their methods a little bit, as well as the fact that this led to them shutting down some of those gender identity clinics for youth, and there's no new services in operation. Like, they just shut down these services in the UK. I would imagine that private services are still available in the UK, which is also a whole can of worms. But yes, and also, WPATH states that they firmly stand by their standards of care, which do support puberty-blocking medication and hormone therapy for transgender young people, and we will get into those. So let's start out with who are trans youth. There's a lot of variation in studies on what percentages of the population and when exactly folks know that they're trans or gender diverse. But globally, survey-based studies of children and adolescents show that 1 to 2.7% identify as transgender and 2.5 to 8.4% as trans or gender diverse. Those are pretty wide ranges. It's definitely very culturally dependent. Probably depends on how socially acceptable that is as well. And in places where they're being counted, it's probably more acceptable to be trans and gender diverse than in places where it's completely not acceptable at all. But in the places where they've counted, those are your ranges, which is not insignificant at all. In a Canadian study on transgender youth seen at 10 clinics, 18.8% of them were assigned male at birth. That's only about 1 in 5, and that does match previous surveys, meaning that the rest were assigned female at birth. So this is different from higher proportions of folks assigned male at birth amongst older youth and adults, and this is reflected in studies globally, the higher proportion of assigned female at birth versus assigned male at birth individuals, including the Canadian Trans Youth Health Survey results in Atlantic Canada, where 81% of respondents were assigned female at birth. So there's some thought that, maybe it's more socially acceptable. Even when you think about how socially acceptable it is to bend gender norms, if you have a little girl who's a tomboy, That's pretty socially acceptable nowadays. Maybe it didn't used to be, but it is now. Whereas the reverse, if you have a little boy who wants to bend a little bit more feminine, that's usually a lot less acceptable.
They have a lot less leeway to just express themselves without it getting tied into sexual orientation. I find it interesting that in the past it was the opposite.
Yes, that historically, when it came to physicians that provided gender-affirming care to adults in, I believe this was mostly the US, but North America, the first initial patients to come seeking this kind of care were mostly assigned male at birth.
And a large part of that has to do with access to the gender-affirming care options.
Mm-hmm. If you need the money and freedom to go and travel and seek out this care and live your own life, if you don't have access to your own financial independence, etc., which is the situation that most women were in at the time, then how would you go seek out that care? It is interesting that it's flipped. We know that not everybody who may benefit from care or want to seek care is able to seek that care in their youth, especially if they don't have parental support. For example, while there was a higher proportion of Indigenous patients seeking care than the general population, there was also a lower overall presence of visible minorities than in community samples, and the youth seeking care also had higher levels of parental support than community samples. There's a high proportion of youth from low-income households or experiencing food insecurity or lacking access to essential resources who are still accessing care at these clinics. So that means that we're doing a decent job at getting care to those of all socioeconomic statuses. The bigger difference is in terms of visible minorities. There's one big Canadian trans youth health survey that was done in 2019. That's the most recent source of data that I'm using for a lot of this. There were Atlantic Canadian numbers that were reported. Our sample size, as usual, was not very high compared to Ontario, for example. It's just our low population, but I am going to tell you what numbers we have. So, in Atlantic Canada, 47% of trans and gender diverse youth reported living in their felt gender at least part of the time, and 31% full-time. So there are a lot of youth who are living in their felt gender part-time, maybe depending on the circumstances, who they're out to, and this means that physicians may be caring for trans youth without realizing it. In the same survey, only 31% of trans youth with a family doctor felt comfortable discussing their trans status and trans-specific health needs, and only 10% felt the same at walk-in clinics. So I wanted to make this point because just because you have someone in your office who doesn't tell you that they're trans, it doesn't mean that they're not trans. So making a point to make your practice and your space welcoming. Also, many youth do not identify with the binary trans identity in Atlantic Canada. 47% of trans youth, in terms of their identity, chose I am transgender and identify in some other way, rather than saying, trans man, trans woman, binary identities. Feels like anecdotally that's been a big shift.
I feel like there were a lot of aspects and qualities of myself that I was like, this just doesn't fit, but it is what it is kind of thing. And it was simply, I just didn't have the vocabulary of what it was that I was feeling to be able to identify as being non-binary.
We're going to talk about the evidence for offering care to transgender youth.
I'm Arati Mokashi. I use she, her pronouns. And I'm a pediatric endocrinologist at the IWK Health Center. I do general endocrinology, pediatric diabetes, as well as I'm the medical director for the gender clinic in pediatric endocrinology for children and youth.
How do you find that these populations compare to maybe your cis youth populations in terms of general health, so mental health, physical health?
In terms of mental health, we know from the research that there is a higher incidence of mental health concerns in young people that are gender diverse. I'm not an expert in mental health disorders, but I certainly do see that more frequently. Having said that, I see lots of teens in diabetes clinic and in endocrine clinic who have chronic conditions where there's also an increased incidence of mental health concerns. But yes, in the gender diverse population of children and youth, there is a higher incidence reported out there. Whether that's related to the fact that these kids are living with dysphoria and living with more minority stresses, just discrimination that they might experience in day-to-day life, people not accepting of them, or having barriers to care, not being able to access the medical or surgical or just even general care that they might need on a day-to-day basis can kind of contribute to those things. In terms of physical health, I think dealing with kids, they're generally healthy from a physical standpoint. There is some literature out there that suggests that transgender people in general or gender diverse youth may not access healthcare when they need it because of fear of discrimination. But the population that I see, they're generally young and healthy kids.
We do know that trans youth face significant mental health disparities in comparison to cis youth, especially when it comes to suicidality. In a Canadian study on transgender youth seen at 10 clinics across Canada, 74.9% of them recorded good to excellent physical health, in contrast with 45.5% for good to excellent mental health. So mental health is definitely more of a concern than physical health. In the same study, trans masculine youth were more likely than trans feminine youth to report depressive symptoms, but suicidality was similarly high overall, with the past year suicidal ideation of 34.5% and attempts at 16.8%, which is high. 65.2% of these youth had OASIS, which is like a screening survey score, consistent with a probable anxiety disorder, and 67.6% had past year self-harm.
Do we have the stats for cis youth?
When it comes to suicidality and self-harm, a 2017 survey of 923 trans youth from across Canada found that, in comparison to cisgender youth, trans youth had a higher risk of reporting psychological distress, self-harm, major depressive episodes, suicidal ideation, and suicide attempts. In the Atlantic provinces, 59% of trans and non-binary youth reported self-harm in the past year. For youth ages 14 to 18, 60% reported serious thoughts of suicide, 40% had attempted suicide, but these sample sizes, again, are pretty low. For youth ages 19 to 25, 77% had considered suicide in their lifetime, and 52% had attempted suicide. Nationally, BIPOC, trans, and non-binary youth have a significantly higher prevalence of suicide attempts in the past year compared to white, trans, and non-binary youth. The number that I found was 24.9% versus 19.5%. And significantly higher violence victimization. BIPOC, trans, and non-binary youth who experienced any form of violence were 13 times more likely to attempt suicide than those who did not report any forms of violence. In the Atlantic Provinces Canadian Trans Youth Health Survey, 33% of youth ages 14 to 18 reported that they had no adult that they could talk to if they were having a serious problem. So consider being that person as a healthcare provider if you can. And just a note about access to healthcare specifically for trans youth in the Atlantic provinces. The survey did mention that 37% of trans youth ages 14 to 18 had needed help for physical health concerns, and 57% for mental health. Exactly why that is unclear. We also have people who don't have family doctors, etc. But I think the idea there is that there are folks who are missing because they should go to a walk-in, but they're concerned about whether or not they will be gendered correctly. There's some healthcare avoidance factors there. I think that's the concern. We talked about all these mental health disparities. What can we do about it? How can we address suicidality in trans youth?
We do know social transition for those that need it can help the child's well-being, for sure. Social transition, it's like a huge sort of umbrella term, but it really is changing your expression of yourself to align with how you feel inside. And for some kids, that's going all the way in terms of, changing their names, changing their pronouns, going from shopping in a boys' department to shopping in the girls' department, wearing pink and sparkles and all of that. But whereas for others, it might just be being recognized for who they are, being referred to at least as the pronoun they prefer at a minimum, or just being listened to. And social transition is something that can help alleviate that anxiety, that feeling that I'm not being listened to for a younger child. And it's in the wheelhouse of all healthcare providers. It doesn't require writing a prescription and discussing side effects of a medication or any of that. It's really just what is the child asking for and following that child's lead. not necessarily pushing them or guiding them in one direction or another. It's more sort of just following their lead, and you see the anxiety of the child start to kind of come down with that. The healthcare provider can talk about the benefits of that, the advantages of social transition, but also caution about, okay, what are some of the barriers you might face along the way, and prepare the family, prepare the child for that. Social transition often is something that happens just organically and slowly in the families where I've seen it happen, where the parents have just kind of gone with the flow. Often the child will tell them, like, I'm only comfortable doing this at home right now, or I'm only comfortable wearing these clothes that I feel comfortable in when I'm in my room by myself. And then might slowly start to venture out, or start to say, okay, I can share with friends. I want to share with these friends, but not with those friends. And then over time, that might then spread to all aspects of their life. So the benefits, I think the main thing is really the well-being of the child and setting them up for success in the long term and reduce mental health consequences potentially down the road as well. Another thing I'll say is just making the child feel safe. You can imagine as a parent, if a child comes to you with an issue and they're just ignored, they're not going to feel safe to bring it up again. And then they internalize that feeling of not being safe. So we can sort of look at it like any problem the child might be coming with, that they're being listened to. In terms of consequences, just really like what happens if they change. Often children, especially young children, we have to allow that fluidity of gender, and their gender might be fluid. So somebody who's been assigned male at birth might be at the moment saying, I feel more female, or I want to use she, her. And that's fine. That's how they're feeling in the moment. But that might be more fluid. They might go on to then identify as non-binary. Or maybe they revert back to identifying as male, but feel more comfortable with kind of stereotypically feminine interests. So things might change along the way. So just recognizing that that doesn't mean they shouldn't transition to what's most comfortable right now, but just kind of working with the family to say, okay, well, so what if they change? Then what? Now you've shared their pronouns at school, then what happens? How do you handle that? Or for a child who is transitioning at school, how are you going to answer the questions that are going to come along from other kids, from potentially teachers to parents? So just preparing the family for those kinds of instances, I think, are kind of the cautions.
If the family was an isolated unit or the child was an isolated unit, the risks don't come with that. The risks come with the outside pressures of maybe people who don't understand that gender can be fluid.
Exactly.
Or people who may not understand the concept of being non-binary or something like that. So it's mostly outside pressures rather than inherent risks to social transition.
Yeah. And the kids I've seen along the way who have maybe changed along the way, the child, for the most part, if they're prepared, they're not distressed by that necessarily.
I really like that idea of also preparing the child that, hey, it's okay if this changes, and so they don't have to feel pressured to make a choice and stick to it. It's okay if there's change.
As long as you haven't done something irreversible. Like if you've prescribed, obviously that's a different discussion, and we'll come to that. But if you've prescribed hormones that are going to lead to irreversible changes, then you are still having that discussion with them. But everything before that is completely reversible, and it's okay, right? This is how you feel now. This may not be how you feel tomorrow or next week. That's okay. We're going to follow you to make sure that you're okay.
We know that the environment matters a lot. One study of the 2015 U.S. Transgender Health Survey found that undergoing social transition between ages 10 and 17 was associated with adverse mental health outcomes, including greater odds of lifetime suicide attempts compared to adult social transition. This is the kind of data that the CAS report kind of skewed. However, once they adjusted for K-12 harassment, the mental health associations were no longer significant. These findings suggest that the social transition itself is not harmful, but that adverse reactions within unaccepting school environments are. So it doesn't mean that children should not be allowed to socially transition because you still have those huge mental health disparities. It means that we need to work on our environments. We wanted to hear more about what it's like for a family to support a child through social transition.
My name is Elsja. Pronouns are she, her. I am a cardiac stenographer. I'm married to my husband, Brendan. We're in Ontario, and we have 2 kids. Our eldest, she is 9.5. Our youngest, he's 7.5. When our oldest was about 5, that's when she told us that she's a girl, and we had assumed she was a boy. She was assigned male at birth. So it's been about 4 and a bit years since we started on this journey, and we've learned a lot. We've been through a lot. We've had to navigate a lot. We're still learning a lot as we go.
Did you feel like you had access to the information that you needed, or did you have to go looking for it? How did you approach that whole learning process?
Our initial place that we found information was a few Facebook groups of other parents of trans youth. I remember shortly after she kind of shared with us who she was, I had a doctor's appointment for something else, mentioned it to our family doctor, and I said, we're still trying to figure all this out. We don't know what this means or what kind of care we're going to need for her in the future. What are your thoughts? And he was kind of lost as well. I think she was probably his first young trans patient. And so I ended up finding information on gender identity clinics. There's one at Sick Kids in Chio, and just asked for a referral to one of those because we said, at some point in the future, we're going to need care. And through the parent group online, we knew that the wait list could be quite long. And so that's where we started. There was not a lot of stuff given to us. It was a lot of our own research.
Have you been able to interact with those specialty clinics at all since?
CHIO actually doesn't take referrals for kids that aren't close to or at puberty. So we were referred to another pediatrician within the community who she had trained at CHIO and done a portion of her training at the gender clinic. And now her practice, she specializes in care for trans and gender diverse youth. And so we've met with her annually since.
What kind of interactions with the healthcare system have you had since?
She's young, so we've had a couple emergency room visits and then just regular doctor's appointments with our own family physician. And seeing our family physician, those appointments are always fine. There's no stress. Everybody there is very affirming and great and supportive. Going to the hospital is always very stressful. You never know who you're going to get, what they're going to be like, how they're going to react to, this young trans kid. I know our first emergency room visit, she had an allergic reaction and had swelling all over, but including on her genitals, which was a whole thing. And so we went in and I asked, do you want me to introduce you with your pronouns? Because they're going to swipe your health card and it's going to come up and say male. She said, yes, please let them know who I am. And so I did, and I asked the triage nurse, can you please make a note on her chart so we don't have to keep reintroducing her to each person we interact with today? And they said, okay, absolutely, we'll make a note. We went to the registration desk and the registration clerk said, oh, I'm looking for so-and-so. And I said, oh, she's just in the bathroom. And the clerk said, oh, I'm not looking for a little girl, I'm looking for a little boy. And I said, no, actually, you're not. There should be a note in her chart. And the clerk was just like, oh, okay, well, I didn't see it there. And I was just very thankful she wasn't there for that interaction. I can't imagine what it would have been like if I wasn't there. She was having to go through that on her own. And I can only imagine what it's like for other trans people who are interacting with the healthcare system and meeting people who aren't, educated or at least respectful or read the notes that are left in places for a reason. No harm was done to her at that point in time, but I don't want her to have a negative experience and that impact her relationship with the healthcare system and prevent her from seeking care later on in life.
That's a really great point. In this situation, because she's a lot younger and you're there with her in all these different contexts, she's kind of protected from it a little bit. You mentioned that you pursued social transition with her. How has that been, and what have you done in order to facilitate that?
When she shared with us that she was a girl, we were eating dinner and it was just, we were talking about some friends who were expecting a baby. And she said, oh, well, I hope they have a girl this time. I hope they have a girl like me. And my husband and I, we looked at each other and I looked at her and I said, sweetie, you said you're a girl. And she's like, yeah. And I said, okay, so you are a girl. And she's like, well, yeah. And looked at me like I already should have known that she was a girl. And I said, oh, okay, I'm really sorry, that we've been wrong and we've been calling you a boy for the past however many years. And she's like, oh, it's okay. And so we just kind of left it that night. The next night we were eating dinner and I said, you said this to us last night. We were wondering, did you want to talk about pronouns and how would you like us to refer to you when we're talking to family and friends? Do you want us to say that you're our daughter and our son's sister? And we had a whole discussion about that. And she was like floored that she would be able to be referred to as she and her. And is that allowed? And that's obviously what she wants because that made sense. And it was so simple and so easy. And so we said, yeah, no, if that's what you want and that's what would make you feel good, that's absolutely what we'll do. We said, you get to decide who you are. So it was a weekend and we put the kids to bed and my husband and I sat down and we were like, okay, I guess we have a lot to figure out and navigate with school and family and friends and all of this kind of stuff because she's ready to just be who she is. And so that weekend we took her shopping and we said, listen, we're going to go in here and we want you to show us what you want. She was a child who her entire life, she always hid. She hated dressing up in typical boy clothes. Like she hated button-up shirts. She hated jeans. She hated being called handsome. And all of this is in retrospect. We're like, okay, things kind of make sense now. Anyway, we took her shopping and she went right to, I'm going to say, the girls section. And she just started picking out clothes that were nothing like anything that she had at home. And she wanted tights and skirts and dresses and all of these things. And we were like, okay. And so we emailed the school and we said, listen, she's coming to school on Tuesday and she's going to look different. How do we navigate this? She's in senior kindergarten. And so her principal and her teachers said, oh, okay, that's fine. We'll just go with the flow and see what happens. I mean, in kindergarten, kids really don't care. It wasn't an issue. And then we went into lockdown like a week later and she started back up the following September and nobody batted an eye. She had a couple of kids give her a hard time and she just said, no, this is who I am. I'm a girl. You don't get to tell me who I am. And now she's in grade 4. So there's been a lot of conversations about certain things within the school system that aren't great. There's staff outing students, not on purpose, but saying to other staff members, well, you would never know this student is trans, would you? Or things like that. There's been a lot of conversations about how we can make things better for all students.
Is there anything that you wish that all healthcare providers knew or considered when talking with all parents, especially parents who may have trans or gender diverse kids or the kids themselves?
Honestly, I think a great goal of the healthcare system would be for all healthcare providers to be given even a basic crash course on gender-affirming care, because it's not just for trans and gender diverse patients, it's all patients. It's important for, I know Rainbow Health Ontario provides online training modules to all healthcare professionals. They're very low cost, but I also know through my own experience in various healthcare systems, I used to work in Alberta and different hospitals in Ontario. There's no training provided that's mandatory. I do know now that more healthcare systems are starting to have optional LGBTQ plus care related modules available for staff if they want to take part, but it's not mandatory. I just wish everybody knew that each person knows themselves best. And even if it's a young child, you should listen to them and believe them, because especially young trans kids, they're not as weighed down initially by gender and social expectations. They're a little bit more free to, or they should be anyways, to explore who they are and figure out who they are. And they're trying to navigate who they are in society and where do they fit. And we should believe them when they say, this doesn't feel right to me, or this is who I am, and give them the space to explore that. We both cut ties with brothers because they don't believe trans kids exist, which has been hard and a thing. With our daughter, it was COVID when she started school. So she was at home. She wasn't in daycare. She wasn't in school for how many months? She was very young. And I remember my younger brother saying, well, where is she getting these ideas from? And we're like, there's been no influence on her. This is just who she is. How can you doubt her? There's been nobody trying to mold her to be a boy or to be a girl. It's just let her be. I don't know. It was really frustrating when his initial reaction was just, well, where is she learning this? I'm like, she's 5. She hasn't been watching YouTube videos or Instagram or anything like that. And if she had been, she probably would have figured it out earlier or told us sooner. It was just really frustrating. Everyone's like, how has your life changed? And I'm like, our child is still our child, and she's free to be who she is now. Whereas prior to her socially transitioning, she was a very shy, reserved kid. She hid from the camera. She was very quiet. And it was like a light turned on as soon as she was able to just be herself. And she all of a sudden was like, can you take my picture? And she's posing for the camera, and she was interested in clothing, whereas before clothes, she would only wear quote unquote comfy clothes, which were track pants and baggy t-shirts or sweaters, because she was hiding. And that was from as early as we can remember with her. And as soon as we opened the curtains, she was just like, okay, this is who I am. And it's been amazing to see her just be.
It's amazing how much there can be done by just letting children be who they are and supporting them and meeting them where they're at.
I asked my daughter yesterday, is there anything that would be important to you for doctors' offices and hospitals and things to have? Our kids point out pride flags everywhere, so they know if we're going somewhere and a place has a pride flag up, it's most likely a safer or affirming space. So healthcare professionals that are wearing a pronoun pin or a pride flag or introduce themselves with their pronouns, it kind of signals this is a safe person. So yeah, just those little things within your practice or within a hospital system can make all the difference for a patient to be like, okay, this is probably an okay person for me to share this information with.
Let's talk about puberty suppression a little bit. When should puberty suppression be considered as an option?
So puberty suppression is not considered until the child is in puberty because it doesn't do anything prior to that. And puberty can start as early as 8 or 9 in kids. And that's kind of the earliest that it would be even an option to prescribe. But puberty starts that early, but it progresses very slowly. So for someone assigned male at birth, they'll start with just a tiny bit of testicular enlargement. And for someone assigned female at birth, it'll start with little breast buds that are not apparent to anybody. And so even at that early stage, there's still time to figure out with the family and with the child what's happening. Are these changes causing distress? And for many children, those early signs of puberty may actually cause no distress. And so, A, are they in puberty? B, is their gender identity persisting now that puberty has started? Because for some kids, they may be identifying a certain gender before puberty, and then puberty begins, and things may start to evolve and change again. And so it's, again, working with the family and the child to figure out, is this persisting, this gender identity? And are they starting to experience distress? For some kids, they may not be distressed by the changes that are occurring right now, in that they have a little bit of breast development. But what they might be distressed by, okay, well, this is signifying what's to come. This is going to lead to periods, or this is going to lead to significant development of the chest, and that's going to cause dysphoria. Or with someone that's having testicular enlargement, they may say, well, this is eventually going to lead to me having deepening of the voice. So even though the changes in the moment might not be causing distress, they might be distressed by future onset of those pubertal changes. And so in those kids, puberty suppression may be an option. WPATH has a set of guidelines that are published. The latest guidelines are the Standard of Care version 8, and they talk about this biopsychosocial assessment, which is basically an assessment that looks at the child, all the biopsychosocial factors affecting that child, the history of their gender identity, the supports they have, how persistent, insistent, consistent has this gender identity been, do they have any other mental health concerns that could be contributing to their gender identity that need to be addressed. And those assessments are best done by a mental health clinician, although a general pediatrician would have the training to be able to do that. A family doctor who sees lots of kids might have the training to be able to do that, although I'd say most family doctors probably aren't as comfortable with children and puberty blockers as, say, a pediatrician or an endocrinologist would be. But the WPATH guidelines actually stipulate that mental health clinicians are probably best positioned and trained to be able to do those assessments. So that assessment is something that's required prior to starting a puberty blocker. A part of the assessment also involves supporting the parents and the family. So if the parents are okay with moving forward with some of the medical options, then they may not require as much support. Or some parents who have worries, validating those worries and helping them to access the supports that they might need, answering their questions, is also an important part of that assessment for the child.
What are the risks and benefits of puberty suppression?
So benefits are that a puberty blocker will block puberty. It will not lead to regression of any of the pubertal changes that have already happened, but it will prevent further progression of puberty. And what it's meant to do is pause puberty and allow the child to further explore their gender identity without having those body changes marching forward that don't align with their sense of self. In terms of benefits, they have been shown to improve psychological well-being. And when looked at in studies, improvements in depression scores for kids that have positive depression scores on questionnaires, and will help with, if you don't develop a body change, then you won't need to reverse that later on. So for example, if you don't develop breasts and you're destined to go on to want mastectomy, if you do develop breasts, then you won't have to have a mastectomy. On the other hand, in terms of risks, any medication comes with risks, and we're blocking sex steroids, so testosterone and estrogen, during a period of time where those hormones are important for bone mineral accrual. And we know that bone mineral accrual steeply ramps up through puberty and into your mid to late 20s, where it starts to stabilize out and you reach your peak bone strength. And what we don't know is, by blocking those hormones for a period of time through that important part of bone maturation, are we preventing peak bone mineral strength? Are we delaying peak bone mineral strength? That's an unknown. There is some research to suggest that this person who's on a puberty blocker goes on to estrogen or testosterone later on, that the addition of those hormones may actually help mitigate the effects. But the studies aren't long enough to look at that. And so, is there potential risk of osteoporosis later on in life? That's an unknown. We do know that there's a correlation between peak bone strength and osteoporosis later on. So the lower your peak bone strength, the higher risk of osteoporosis, but we don't know whether that's a possibility. I've had families tell me, I don't want my child to start breaking their bones while they're on these puberty blockers. We know that that's not going to happen. It's not weakening your bones, it's just preventing bones from strengthening.
So the risk is more that osteoporosis later in life.
Exactly, yeah. The other potential risk is for a person who is born with testes, assigned male at birth, who is now identifying on the feminine spectrum. If they later go on to desire vaginoplasty, which is a surgery that involves the creation of a vagina, the creation of the vagina requires mature scrotal skin and penile skin, which is then sort of inverted to create the lining of the new vagina. If they don't develop their genitalia, so they don't go through puberty, they don't have developed genitalia, then they may not be able to have that type of surgery. They may have to have a different type of surgery, which is more invasive, involving using peritoneal lining as the lining. I do mention that when I'm talking to families, especially when they're really young. That's the group in which that could be an issue. We know that brain development occurs through puberty as well, and so this is an area that's unknown. Like, how do puberty blockers change brain development along the way? And then how do the addition of hormones, estrogen and testosterone, mitigate that effect, or maybe mitigate that effect when they're at it? That's also an area that's not known. If you block puberty very early, then another risk of that is the gonads don't mature.
Right.
So then you're kind of taking away that child's choice in terms of whether or not they want to have their own biological children down the road. And that's a decision that the parents make on behalf of the child, because a child that age really doesn't have the capacity to fully wrap their heads around that decision.
And at what stage would you be pretty sure that you're taking away their fertility moving forward?
If you have ovaries, then your ovaries aren't fully mature until you start periods. So really towards the end of puberty. And if you have testes, it's also later in puberty, but I don't know that there's a specific time where for sure the sperm are going to be mature, but you have to be quite far into puberty for both.
Do you often see it as a barrier to moving forward with the care, or no?
It's a concern for the parents,
Yeah.
for sure. It's never a concern for the kids. They're not developmentally there.
Right.
From a medical standpoint, it's a concern for me. But I think the important thing, again, it's like with every risk, it's like having that conversation. Now, when you start a puberty blocker, it's reversible. So until you add testosterone or estrogen, you can still stop the puberty blocker, and then they would go through puberty. So if something changes in terms of their gender identity along the way and they want to stop the puberty blocker, then they would go on to fully mature. But it's having that conversation that we're starting this puberty blocker. For many kids, they will go on to access hormones later on. And for those kids that do, we need to have this conversation now about the potential risks to fertility. And then I have another discussion about fertility when the child is older and starting on testosterone or estrogen. Recognizing again that even at 15, 16, you may not be able to fully comprehend the risks related to fertility and not know, what your desires are going to be for that later on in life.
Do you have anything specific that you usually cite as the potential harms of not offering treatment? Whether that's puberty blockers specifically, or whether it's hormones, or whether it's social transition?
I often, when I'm presenting, use a slide that shows the data from the TransPulse study. That was a survey-based study, but it was a large population of youth, not just teens, but it went all the way up to 25 in Ontario. And that particular study suggested that people that had decided that they wanted to transition, but weren't able to transition for various reasons, whether that was barriers to care or lack of support or other reasons, that their mental health significantly deteriorated during that time. And the suicidality went up. So they looked at suicidality in the past year or suicide attempts in the past year, and both of those went up significantly during that period of time. Knowing that, and we see that for the kids that I see, that their mental health can deteriorate further if they're in situations where they're not able to access the care that they need. We know that withholding hormones or withholding any kind of gender-affirming care is not neutral, that there's harms associated with that.
Once somebody's been on puberty blockers for a while, what would be the next step after that?
Once a child is ready to start undergoing puberty, they can start pursuing hormone replacement therapy, and there are just some additional guidelines for that. So the WPATH guidelines are that the adolescent meets the diagnostic criteria for gender incongruence in the ICD-11, that their experience of gender diversity is marked and sustained over time, that they have the emotional and cognitive maturity required to provide informed consent or assent for the treatment, and that if there are mental health concerns that may interfere with diagnostic clarity, capacity to consent, and gender-affirming medical treatments, that these mental health concerns have been addressed. And also that they've been informed of the reproductive effects of doing so. And we have a whole other episode about fertility, and we do talk about adolescence in that. Do you have any unique considerations for prescribing gender-affirming hormones to youth versus adults? Are there any major differences?
I don't prescribe to adults. I only prescribe to youth, but the protocols that we use for youth are different than those used for adults. The doses started very low and it's increased very, very slowly over time. So typically increasing only at 6-month intervals. And just like in adults, the care is individualized. Not everybody gets to the highest dose. Even though you can increase at 6-month intervals, not everybody wants to increase. They might start at a low dose and stay at that low dose. The changes that happen because of how slowly the hormone doses are increased happen very, very slowly as well. And knowing that youth, their brains are not the same maturity level that they're going to be when they are in their mid-20s is a reason to do that, is to go just slow to kind of mimic what the hormones would do through puberty.
We'll talk a little bit about surgery. You can't get most gender-affirming surgeries until you are 18 in most provinces, with the exception of top surgery, which you can sometimes get as early as 16, but that will be addressed more in our adult episodes because all the barriers to that and that whole process is something that you encounter more as an adult. But when youth are able to access puberty blockers and gender-affirming hormone therapy as youth, there may be fewer or no gender-affirming surgeries that are necessary in their future. Not everybody will want to pursue surgeries regardless, but we just want to mention it's also a way to avoid these more invasive procedures in the future if a youth has a somewhat stable idea of their gender and they want to pursue those early options. Youth who are under the age of 16 are not out here getting surgeries. That's a common political talking point, that youth might be getting all these surgeries really, really early and it's easily accessible to them. That's just not true.
Yeah, and that even goes for hormones and puberty blockers. That's also not something that is quote-unquote easily accessible. It's not something that's happening within the first appointment. There's a lot of things that need to happen. They're not going to their family physician and leaving that office right away with puberty blockers.
Just a note about barriers to care overall. There are only so many Canadian studies that I found, but a study in BC found that while youth who sought hormone therapy were clear about their decisions to access this care, youth with the lowest levels of parental support experienced more system barriers, as well as non-binary and gender-fluid youth. That's just something to consider, that youth who do have parental support, and that may help with their overall levels of distress in general, are also going to have an easier time accessing this care, which makes sense, especially when they're still under 16, under 18, and having to go through their parents for a lot. Even though, for example, in Nova Scotia, we don't have a set age of consent. It depends on the procedure and on the context. And so there could be scenarios where a 15-year-old who is absolutely certain could maybe find a way to access this care. It's definitely not easy.
And going back to your point about kids rely heavily on their parents, obviously, especially when it comes to things like insurance.
And puberty blockers are expensive.
Yeah, and so if your parents don't know or they are not on board, then you obviously are not going to be able to utilize their insurance coverage to be able to acquire that medication.
In Canada, in general, consent for medical therapies is based on capacity, and there's no age of majority specific to any medical treatments. And so that same applies for gender-affirming treatments. And for the most part, in other areas of medicine, it's kind of a non-issue. It's understood assent. So if we're talking about antibiotics, you're telling the child and the parent about the benefits and why we're giving you this. You're telling them about the risks and side effects, and you're prescribing it, and the child says, no, I don't want it. And then you're convincing the child, no, you need this. Yeah. Or the parent is like, I'm not really into antibiotics. And you're explaining, okay, yeah, they need it. And for the most part, it just happens, right?
Right.
Whereas in this situation, you're dealing with a child who wants testosterone. The parent doesn't want the child to have testosterone. You've tried your best in terms of explaining the risks, explaining the benefits, referring the parent for support, providing the child support, getting the mental health clinician involved. The way that they work, not that they have more time, but they have more expertise and can block their time in a way that can spend a bit more time with the family and the parent. So you're trying all those avenues before you are saying, okay, this child has capacity for consent. Recognizing that now this child is going into a home where the parent is not supportive of this. The parent needs to be able to pay for the hormones because the youth may not have the means to do that. So there's a lot of complexity to just saying, okay, we're going to go with the mature minor doctrine. That means this child has capacity. They can consent for themselves. So I'm going to give them a prescription. It's not as simple as that. So I think that's something that not everybody understands unless they've been in that situation where they're trying to convince someone that this child needs this, and that you can prescribe to that child without the parent's consent, although it's not ideal and it's not something that's approached lightly.
We talked about surgery, which is highly politicized. Another area that is politicized is detransition. What do we know about the rates of detransitioning?
Based on a narrative review of studies, the WPATH standards of care found that rates of reported regret are very low and rates of detransition are low. And overall, the evidence base shows a general improvement in the lives of trans adolescents who, following careful assessment, receive medically necessary gender-affirming medical treatment. But there is a big research gap. It was a narrative review because there were not enough studies to do a systematic review. But yeah, by and large, what data we do have shows that our fears of really high rates of regret or of damage to children just do not bear out, and there's a lot more damage done by not supporting children through their transition. Although there is a bit of a research gap in terms of detransitioning because the big cohorts that we have haven't grown up yet.
Yeah.
Another thing, I mean, this is from what I know about research done on adults, but some of the regret can be attributed to social factors, so people not having support and facing discrimination.
Yeah.
Another thing, I think detransitioning is not necessarily the end of the world.
Yes.
And for someone to have some fluidity in how they identify, it might not be as devastating as some people imagine.
Yeah. There's also data that found that of folks who detransition, there's a huge percentage of them that don't regret transitioning in the first place.
Yeah.
It was something that needed to happen in order for them to learn about themselves, or it was something that made sense at the time, or it was something that was affirming at the time.
Yeah.
And it's true that gender can be fluid. One thing to think about, too, when it comes to kids is that for kids whose gender is very fluid, or they're not sure what they want, or they're not sure if this is what they want, those are not the kids who are getting surgery at 16. And I should say only top surgery. The kids who are pursuing that care early are the kids who usually have more stable ideas of their gender and experience a ton of dysphoria and are doing it because they need to do it.
And that's why puberty blockers are so great, because they give you time.
Yeah, because it's temporary. So gives you that opportunity to explore, to be fluid with your gender, to see who you are, and it's open to change.
Yeah. And it's interesting that puberty blockers are so politicized because puberty blockers are the one reversible part of all of this.
Yeah.
Where you actually can just try it out, and obviously it's not zero risk, but it's lower risk than the other components of this. There's no permanence to it, and puberty blockers are used with cis children regularly for precocious puberty, etc., and we know that they're pretty safe. Is there something that you wish that all healthcare providers knew about caring for gender diverse youth?
It's important for people to take a step back from all of the rhetoric that's out there and just recognize that this is a person walking into your office who needs your help. This is a population of children and youth specifically, I see, but in general, a population of people that are already afraid to come into your office and see you, and having a positive experience can really make them feel safe in future healthcare encounters. Even if you are not the expert or you don't feel that you're the expert, there are courses out there. If you have the time and desire to get that expertise, that's great. If you don't, then at a minimum, understand what the resources are in your area so that you can help people when they come to you with specific gender-related concerns.
Well, that's the end of our episode. I will be putting the links to some helpful resources in the episode description, and you can find us at genderqueriespod on social media. Thank you again for joining us, and have a lovely day.